Welcome to the fourth and final day of the Toronto Academic Health Sciences Network, TASN Innovation Fellowship Program, Final Project Presentations. I'm Deborah Wildish, and I co-lead this TASN program in partnership with Carrie Ann Smith from UHN, Sarah Morasai from Sunnybrook, along with Lisa D. Prospero, and other faculty, including Guna Badrevics, Nicole Cooper, and Bridget Hales. Today's event is being live streamed, and a warm welcome to all of those joining via telecast. The Innovation Fellowship Program provides frontline health professionals with paid protected time 2 days per week for a period of 6 months to help them develop leadership competencies while planning and implementing a quality improvement project. Project ideas emerge from each clinician's experience in direct patient care. And projects aim to implement best practices, bridge gaps, and re-engineer clinical processes and service delivery while aligning with organizational priorities to promote safe and high-quality practices. Fellows have a very broad support network, beginning with their funders, the foundation work, securing donors to fund different fellowships, along with program funds. Partnerships with patients and families to support the projects. Clinical managers who arranged release time. Committed mentors. Colleagues, many of whom become change agents to help move the projects forward. And leadership at Sunnybrook and UHN, especially senior executive sponsorship by Ruth Taggart and Joy Richards. Today's event is dedicated to our fellows here today. This is a culmination of 6 months of hard work, overcoming challenges and harnessing enablers while engaging in a variety of education seminars. Fellows completed and earned the Ideas, Improving and Driving Excellence Across Sectors workshop certificate to launch their skill development and quality improvement. Each fellow's leadership journey entailed carving out their own path. I will conclude with a quote from Ralph Waldo Emerson. "Do not go where the path may lead. Go instead where there is no path and leave a trail." That is what Jordan, Chang, Zara, and Robin have done. That is what leadership is all about. Let's commence today's presentations.
Thank you, Deborah. I'm Sarah, and I'll be introducing each speaker. First, we have Zara Abbas Ali Madadi, a registered nurse from Sunnybrook. Thank you.
Good morning, everybody. My name is Zara. I'm RN in D3. D3 is Cardiology, Vascular, and Cardiovascular Unit here at Sunnybrook. And my project is about the effectiveness of education to improve patients' hand hygiene. First of all, I want to say thank you to those who helped me in this project. PBRI and TASN program leaders, Sarah, Lisa, Deborah, and Carrie Ann, and also Schulich Heart Center, the director, Susan, my mentors, my unit manager, Garcia, and also nurse educator, Tika, infection prevention and control fellow, Dr. Glenn, and coordinator, Kuldip, and also all D3 staff and patients, and those who helped me throughout this fellowship program. Each year, millions of patients around the world are affected by hospital-acquired infections and related complications. We spend a significant portion of our time and resources to manage these preventable infection and related complications. The word preventable, I want to relate it to WHO's most important suggestion to prevent this kind of infection, that is hand hygiene. So simply with hand hygiene, that is a simple but effective way to prevent, we can prevent those type of infections. Did you know that patients' hand hygiene practice at home are better than in hospital? For example, 85% of patients reported washing their hands at home compared to 69.5% at hospital. And did you know that patients' hand hygiene is as important as staff hand hygiene? It is a big step in infection prevention and safety according to the literatures. But how can we promote our patients' hand hygiene? Researchers believe that an easy and effective thing that a hospital can do to promote patients' hand hygiene is education. So the purpose of our study was to improve patients' hand hygiene, compliance, and knowledge on Unit D3 by education by March 2019. So what is our method? We started with staff survey and education. A survey done on the staff to get their feedback and remind them about the importance of patient hand hygiene and moments of hand hygiene. Also, this sign posted on the unit's visible areas, such as boards and bathrooms, and also email to the nurses. We discussed about hand hygiene during quality conversation and hand hygiene huddles, and also one-to-one discussion with staff. Based on 14 surveys that we got from the nurses, we had some barriers that they mentioned to, that prevent them from educating patients about hand hygiene, and also some suggestions to improve hand hygiene. The most important barrier was busy unit and heavy workload. And also they are not at the bedside all the time to remind the patient. Patient refusal, language barriers, time restriction, and also confused and level C patients. Level C, that those patients who cannot stand up or be on the chair. They had some suggestions to improve patient hand hygiene, including educating patients frequently using some tools, such as video player, pamphlet, posters, signs, stickers, and also if you can use wipes in the food tray. Automatic hand sanitizer be available to use, and also teamwork, time management by nurses, including hand hygiene discussion among RNs. From the patient side, we had 20 patients involved in this project, 14 males and 6 females. We started with the project method is pre and post education survey done. So we had first survey 24 hours after patient admission to the unit, and then education session done 24 hours after the education. Also we had another survey done to compare the pre and post education knowledge and compliance. So about the education, we used 3 strategies for patient education. First of all, patient information sheet, which talked about importance of hand hygiene, the methods of hand hygiene, and moments of hand hygiene for patients. Also, we put some stickers on our bedside table hand sanitizer to remind the patients about cleaning their hands, and we put the sign of 4 moments of patient hand hygiene on the patient's board. Because of the patient privacy, I didn't take photo of that boards, but this sign that you can see in the picture, it's from our patient lounge room. It's on the cupboard. So after the all intervention done, I put that signs around the unit, like where that the patients can see, to just maintain our sustainability. And what are the results? So about the compliance, as you can see in the chart, the first chart speaking about hand washing. So patients hand washing before education and after education. I just put the mean frequency of hand washing. So it's like it was 3 times a day. That increased to 5 for females and 4 for males. And also about hand sanitizer usage, it was 2 times a day in average. That increased to 8 for males and 4 times a day that increased to 8 for females. We can see that in both charts, we can see that females in general washing their hands more than males. And also the result was the significantly difference that before education. That shows that education can increase patient compliance. Our goal was 15%, but we can see with education we can increase the patient's hand hygiene compliance by even more than 50% to 100%. About patient knowledge. So I talked about 4 moments of patient hand hygiene. You can see that 4 moments in this chart. Almost like all our patients did know that they need to wash their hands after bathroom, bedpan, or commode. So it was 20 of 20 patients before and after education do know about the importance of hand hygiene in this moment. But the first top missing part was when they're entering or leaving the room. That it was 3 patients didn't know about that, which after education increased to 15 patients. This is really common time in our unit because we're sending our patients to different areas like X-ray, pacemaker clinic, other ultrasound, echo, and different test areas. And then they're touching that area and coming back to their rooms. If they don't know that they should wash their hands or clean their hands in that time, they may bring everything from the other unit to our unit and their own bedside. Also, before and after touching their wound and devices is the next missing part. That was 6 patients did know about that, which increased to 17. It's also really important. We have so many devices and also wounds in our units, such as vascular wounds, cardiovascular surgery, different type of wounds, and they sometimes I saw that they're touching their wounds without washing their hands. That's good to remind them and educate them in this part as well. They know about before eating, drinking, and taking their meds. It was 13 patients that increased to 20 as well. So we can see that the difference of before and after education about the knowledge of patients also was significantly notable. So I also got some feedbacks from patients based on the surveys that was done. So like barriers that prevent them from hand hygiene was bed rest, pain or weakness, skin dryness, IV line on hand, and sanitizer not within their reach or empty. Also, some of the patients didn't know about the bedside hand sanitizer or didn't know that they are allowed to use that bedside hand sanitizer. That nurses can simply just remind the patient or other staff that is bedside hand sanitizer and you can use it. That's why we put the sticker on that. Some suggestions such as, is that possible to have education session earlier in eMERGE or other units? Example, I discussed about this with infection control coordinator, if they can just start hand hygiene in other units or earlier than V3. Using hand wipes is very easier for an immobile patient like me. Just like another suggestion from patients that we discussed. Again, I'm gonna transfer all these suggestions from nurses and patients to infection control department and my unit manager. So in terms of sustainability plan, So we will continue our discussion about hand hygiene. We have hand hygiene, staff hand hygiene huddle in our unit. It's daily, so we can simply remind the nurses to also educate their patients about hand hygiene, and also during our quality conversation sessions, maintain our science and information sheets on unit, maintain hand hygiene stickers on bedside hand sanitizers, and also put the poster in the unit. What is our next step? So we will send the information sheet that we use in this project to the infection control department. Maybe they can use it. It's just a draft. Maybe they can use it in other units and also be like all the time in our unit as well. Send staff and patients feedback to the unit manager. Share the project result with unit staff, manager, educator, and infection control department. And also, I started my publication process because I want to share my result not only with Sunnybrook, but also with other healthcare facilities around the world. So finally, clean hands save lives. So let's clean our hands and also educate our patient to wash and use hand sanitizer in that moment, especially to prevent them from infection and maintain their safety. Thank you for your attention. Any questions? Okay. Thank you.
Thank you, Zara. Okay, up next we have Jordan Fillion, registered dietitian from Sunnybrook.
Good morning, everyone, and thank you so much to all of you for taking time out of your busy mornings to attend our presentations. My name is Jordan. I'm a clinical dietitian in the Veteran Center here at Sunnybrook, and I'm very excited this morning to be sharing with you my fellowship project, which involved implementation of a clinical pathway to guide preoperative hydration among surgical patients. For the remainder of this presentation, I will be referring to this pathway as the PHP. So whenever you hear me saying the word we throughout this presentation, I am referring to this very long list of individuals and groups who, without their support, this project certainly wouldn't be possible. Aside from my two mentors, Dr. Claude Laflemme and Caitlin Maniatis, I would also like to make a special shout out to Jerry Hubble and Dr. Kelly Fedoric, who worked very closely with me over the past 6 months, as well as Catherine Confrey from Quality and Patient Safety for all of her guidance and support. I'm going to be starting off today by providing you with a brief background on my project topic, including impact on patients and staff and results from our needs assessment. I'll then be walking through some of the steps that we took for our project design and implementation, touch on some of the sustainability and our preliminary results, and then wrap up with some concluding remarks and open up the floor to a few questions. So strong evidence has existed in the literature for about 2 decades now, suggesting that in the majority of cases, it is safe to feed patients solid food up until 6 hours preoperatively and provide clear fluids up until 2 hours preoperatively. Before this project came along, it was routine practice for patients who were admitted to hospital for a non-elective surgery to be made NPO, or start fasting at midnight on the day of anticipated surgery until after the patient returns from the operating room. When patients are booked for a non-elective surgery, they're booked as either an A, B, or a C case, depending on how urgent their surgery is, with an A case being the most urgent and a C case being the least. Patients who are booked as C cases are particularly vulnerable to undergoing prolonged periods of fasting, mainly due to their tendency to being bumped by more urgent cases coming into the hospital. Data that we collected from neurosurgery, orthopedic surgery, and trauma patients who went to the operating room as a C case over a 3-month period back in 2018 showed that patients were spending an average of about 69% of their preoperative time on the unit fasting from food and drink. Furthermore, only 1 in 20 patients were found to be meeting best practice guidelines of consuming clear fluid hydration up until 2 hours before their surgery. When we asked a sample of patients to fill out a hunger and thirst scale right before they went to the operating room, we found that preoperative thirst scores were higher than hunger scores, indicating that the dehydration aspect of fasting was more uncomfortable for patients. One key factor contributing to these fasting statistics that we identified throughout our fasting or our needs assessment was lack of a standardized protocol for communicating updates in OR scheduling from the OR to the nurses on the unit. So the first step that we took in designing our project involved adaptation of an existing preoperative hydration pathway to our local context. The pathway shown here was originally created about a decade ago by a group of UK physicians and trainees working in anesthesia. Our main focus from October to December of last year was on stakeholder engagement and consultation to get a sense of how we could best tailor this pathway to the unique needs of our surgical populations here at Sunnybrook, while also remaining logistically feasible. After many meetings, countless revisions, and some graphic design magic, we were able to arrive at our final version of the pathway, which our stakeholder group met the needs of all of the stakeholders involved. While we were busy creating the pathway, we were also simultaneously developing a medical directive that would allow nurses to initiate patients on the PHP who met a set of eligibility criteria, and then also act on the hydration information that was being communicated by the OR. So here's a map that shows all of the steps that we went through in this medical directive process. So we started the whole process around mid-November, at which time an initial draft was completed of the medical directive, and this was sent out for review by stakeholders and the medical directive committee. After getting the go-ahead from these groups, I then presented the proposed directive to the medical advisory committee in mid-January, at which time it was approved. We then had all of the relevant surgeons sign off on the directive, had a number assigned to us, and then we actually went live on SunnyNet with our medical directive on February 11th. Alongside the first two steps, we also brainstormed how we could best communicate this hydration information from individuals in the OR to nurses on the unit who were actually acting on this information. So whereas the original pathway from the UK relied on telephone calls being made, one unique aspect of our pathway is that it uses Sunnybrook's very own OR tracking system called TrackOR as the communication channel. We started by scheduling OR huddles throughout the day to serve as a venue for the coordinating team to review the potential ordering of cases, and it was from this huddle that they would make all of the decisions around whether or not a patient could be hydrated. For the purposes of this pilot, we did focus our efforts just on the C cases that were booked for surgery, since those patients were tending to wait the longest for their surgery. So the idea here is that if the patient is anticipated to go for surgery within the next 2 hours, a red icon would be entered beside their name in the OR tracking system, signaling to nurses on the unit that the patient would not be able to receive oral hydration at that point in time. If the patient was not anticipated to be going to the OR within the next 2 hours, the OR staff would then enter a green icon and a corresponding hydration cutoff time that they would decide on at that huddle. Finally came the creation of staff and patient resources, as well as promotional materials to help increase staff awareness of this project. So to make things fun, we involved staff in brainstorming and voting on a catchy slogan, which we arrived at: hydrate while you wait. We then incorporated this branding onto all of our promotional materials for the project, including this project poster, and a lot of the patient and staff resources, including these patient laminated handouts, Cardex reminders, as well as lanyard tags that we're currently in the process of making. After the project design phase was completed and the medical directive was approved, we then took on the task of training 139 nursing staff who were rostered to C5, D5, and the ACNRT pool on the medical directive. Training consisted of a 15-minute PowerPoint-based in-service, TrackOR demo, and completion of a brief quiz to assess nursing competency. After running the in-services for 3 weeks, we then proceeded to go live with all of our intervention components across the C5 and D5 inpatient units on February 11th. So now I wanted to go through some of the preliminary results that we obtained in the first 4 weeks of implementation, over which time we had 17 patients who were initiated on the pathway and stayed on the PHP right up until their time of surgery. These outcome results are geared towards our 3 main outcome measures of interest, which include the percentage of patients consuming clear fluids up until 2 hours preoperatively, which is considered best practice, median percentage of total preoperative time spent NPO or fasting, and then lastly, median preoperative hunger and thirst scores, which were subjectively reported by patients. So with respect to our first outcome measure, none of the patients who were initiated on the PHP drank right up until 2 hours before surgery. Implementation of the PHP was, however, associated with a reduction in time between last drink and surgery. So we can see on this graph here that the blue bar at baseline, we can see the time between last drink and surgery was 13.6 hours, and post-implementation this had decreased to 4.8 hours. Of the 17 patients who followed the PHP right up until their surgery, we did have 3 come very close to the 2 hour mark, either drinking up to 2.3 or 2.5 hours up to surgery. This run chart shows results for our next outcome measure, which is percentage of preoperative time that patients spent fasting while they were waiting for surgery on C5 or D5. So the set of 20 points that you see plotted to the left of the vertical dashed line represent all of our baseline cases, and the 17 to the right represent all of the cases of the patients who were on the PHP up until surgery. So the median percentage across these two groups was 60%. However, when we broke things down into the baseline group and the post-implementation group, we actually had a reduction in fasting time from 79% to 38% post-implementation. Looking at our third outcome measure, preoperative hunger and thirst, we asked staff to administer a survey to patients who were on the PHP containing hunger and thirst scales, with the intent of capturing how hungry and how thirsty these patients were right before they went to the OR. Although we did observe a slight decrease in preoperative hunger and thirst scores, unfortunately our low response rate precluded us from making accurate conclusions about the impact of this initiative on preoperative hunger and thirst. Thinking about sustainability, we have engaged team leaders and APNs on both units who will assist us with monitoring staff compliance and supporting ongoing education needs among nursing. Jerry, who is one of the key collaborators on this project, will also continue analyzing data and also examining the impact of this initiative on both staff and patients through satisfaction surveys. Once we have demonstrated sustainability on our 2 pilot units, women and babies in the burn unit are actually 2 units within Sunnybrook that have already expressed some interest in adopting this. So that is really going to be our next step. And then eventually we would like to spread this initiative across the hospital and even beyond the walls of Sunnybrook. So I wanted to conclude my presentation this morning by sharing a quote from a patient who was initiated on the PHP last week. And this is a patient who had transferred to Sunnybrook for his surgery after being admitted to another hospital. The patient said, "You're already uncomfortable, and not having water or juice just aggravated the whole thing. When I came to Sunnybrook, I was told of a new program that had just started called Hydrate While You Wait, where I could have clear fluids up until my surgery. When they mentioned this protocol, I hadn't been eating or drinking for 20 hours. Even the Jell-O, something that I hadn't had in years, was like getting a steak dinner. It was just Jell-O, but it wasn't. It made a huge difference." So here at Sunnybrook, our mission is to care for patients and their families when it matters most. For me, being able to positively impact someone's hospital stay made every minute of this fellowship worth it, and it just goes to show all of us that through our projects, we're able to touch someone in some way, even if it's through something as small as a container of Jell-O. Thank you, everyone. Does anyone have any questions? Thank you very much.
Thank you, Jordan. So we are running ahead of schedule, but we're going to stick to the schedule in case people want to tune in for particular presentations. So we will take a short break to network and have a poster viewing session and grab some snacks. And for the online people, we will come back at 10:20 for the next presentation. We had a good networking break, thank you. So the first speaker after the break is Robin Wall. She's a registered nurse at UHN.
Hello, everyone. My name is Robin Wall, and I'm here to talk about my presentation on improving pressure injury prevention documentation on my unit of 6A transplant nephrology. Before I begin, I want to take a second just to thank everyone who has helped me with part of my project, everyone from the CAP Fellowship Group, the Hospital-Acquired Conditions Pressure Injury Team and Skin Health Committee, as well as the leadership team on my unit. When we discuss hospital-acquired pressure injuries, they're frequently referred to as being a never event, in that we have the insight to avoid them in many circumstances, even amongst complex patients. However, between April 2017 and July 2018, there were 474 pressure injuries reported, 12 of which were classified as serious safety events, meaning that they were stage 3 or greater. While the patients on our unit have high intrinsic risk factors for acquiring pressure injuries, it's often left to nursing to address the extrinsic factors. So this requires us to use comprehensive prevention strategies such as reducing moisture and shearing forces, using pressure redistribution surfaces, optimizing nutrition, and frequent mobilization. I chose to focus on documentation because it's really only in the presence of clear documentation that we can say that a pressure injury was unavoidable. And it's really essential that our documentation becomes a good communication tool, not just for the plan of care, but also in terms of professional accountability. The previous practice at UHN did not clearly identify opportunities for nurses to show evidence of planning, nor evaluation of those interventions that were selected, and that's since changed. What my goal was for my project was to have an average of 80% adherence to the documentation standard pertaining to skin health. Well, we really strove for 100%. The benchmark of 80 was chosen in part because we often have patients that are admitted for a short period of time because they were called in for their deceased donor transplant surgery, but it was canceled for outstanding circumstances. I wanted to make sure that while I chose an educational model, that 80% attended my in-services, that 95% of those who attended the in-services completed on quiz. There was a 15% improvement on knowledge, and that 90% of patients had a current pressure injuries prevention care plan that was reflective of their acuity. There are 3 main components to my overall project. Good communication to staff about updates regarding the project overall and benchmarks and how we were doing, practice reminder posters and workstation reminders. There were 2 main in-services, one that focused on the practice change and introduction of a pressure injury prevention care plan, and then a subsequent in-service that focused more on developing insightful pressure injury prevention care plans. We also had weekly chart audits that were posted on our quality board. So during daily safety huddles, that became a topic of discussion. There were lots of just-in-time training when there were teachable moments appeared. Conducted informal and formal focus groups with nursing and our unit council. And there was frequent dialogue and feedback up to the leadership team about how things were going and evolving as well. Now, while I wanted to stay away from a traditional education-based project, this was really reinforced by a 2018 Cochrane review about pressure injury prevention education to staff that concluded that they were uncertain whether or not there was any difference in knowledge based on whether or not staff had received education or not, regardless of the format, albeit their review had a low certainty of evidence. I felt that it was more important to take staff beyond just knowing what's best to doing what's best. So I used the integrated behavioral model to kind of underpin my approach to all of my interventions, where I wanted to target my strategies to change nurses' perceived norms about pressure injury prevention, their attitudes towards pressure injury prevention, as well as improve their sense of personal agency about enacting these strategies. These three components really shape a nurse's intention or any person's intention and leads to subsequent change in behavior. It was through this that I wanted to make sure that nurses on our unit had a very common outlook about pressure injury prevention and had a better and improved shared meaning and value about this. On the surface, the first in-service that we did was about the change in practice. However, again, going beyond a didactic session, we did a couple of really fun activities. The 5 white pieces of paper each outline a different category of pressure injury prevention. So reducing moisture, reducing friction and shearing forces, optimizing nutrition, frequent mobilization, and also frequent surveillance of skin. And what I had the nurses do was they were given sticky notes and had to put up on one of the pieces of paper the ways in which they do this as part of their practice, which led to some really innovative strategies. So one nurse, for example, posted that she encourages her patients to eat meals with their family when they come to visit to help improve nutrition, or encourage patients to ambulate to the TV lounge rather than watch TV in their room. One of the things that we did during this is I used an appreciative inquiry approach to help facilitate that development of that shared vision and have more insight from the staff of their perspectives and their attitudes towards pressure injury prevention. And this was really necessary for later and further reorienting their attitudes and making sure that they recognize that a lot of aspects of pressure injury prevention are already embedded in their practice when they had difficulty perceiving it as a frequent skill, or more importantly, not necessarily thinking and valuing the impact of all of these various strategies have. The second part of the in-services was one-on-one and was about developing insightful pressure injury prevention care plans. I used the Institute for Healthcare Improvements framework for improving joy in work to help steer discussions about how nurses ensure that documentation captures their true practice, and show and emphasize to nurses that we need to make sure that we are showing evidence of our own clinical judgment even when using standardized tools. So together we identified at-risk patients. We completed a head-to-toe skin assessment together and documented that, and it gave an opportunity for the nurses to see where we can do things like document prophylactic dressings, that sort of thing that show extra prevention strategies. We collaboratively developed that pressure injury prevention care plan based on this assessment. And to help improve personal agency, I got nurses to fill out the order set for our medical directive to treat stage 1, stage 2 skin tears and moisture-associated skin damage. To help with this, I created a little wound care product algorithm that shows what products are best used, and this aligns with our UHN policy, so that they could have a way to reinforce good clinical judgment. The key thing as well is in the lower left-hand corner, it outlines the steps of what to do if a nurse then finds a new pressure injury. So beyond just documenting that there is a new injury, reevaluating the pressure injury prevention care plan and properly communicating that, the last key bit was encouraging nurses to submit incident reports when pressure injuries develop. It's easier at UHN for us to track and gain feedback using our incident report system rather than tracking new wounds in EPR, our overall electronic medical record system. And stressing to the nurses as well that our online incident reporting system actually has fields specifically already in place for pressure injuries. Again, stress the importance of why we need to submit these, and that is a very serious thing to take into consideration. In terms of how we did, the yellow line on the graph shows what our practice expectation was, that percentage of completion. So for a grade and risk assessment, nurses are expected to complete the grade and risk assessment daily. I found that I wasn't surprised that it began above our target baseline of 8, since this wasn't a new practice and should have been ingrained in the nurses. But there was a little bit of a dip shortly after we did the first initial in-service. This may have been because nurses were confused about the practice change. They felt that they had to do it every shift, and it's not wrong if they did, but some of them decided to stop doing it, and they didn't necessarily know or realize that no one had done it the previous shift, or no one had done within that 24-hour window. With the second in-service or that workshop that we did, we saw our numbers continue to rise and improve above what we needed to do and regain from that possible confusion. And you can see with the bar graphs, a lot of nurses chose to, again, continue to chart every single shift, and that's perfectly fine. We had a lot of trouble getting good documentation rates with our head-to-toe assessment. The orange line is our days, and that continued to fluctuate. And blue is our documenting on nights. The expectation is that every shift we document a head-to-toe assessment. Should note that around week 9, when I started the second in-service, we found that one of our patients unfortunately developed a hospital-acquired pressure injury. So there was a big push after that when nurses were hearing during safety huddles, our managers experienced going through chart audits, meticulously trying to search and find all the available documentation that was there, that there was a big, huge push and encouragement to improve our documentation rates further. So that's in part why I think our numbers continue to rise after that particular time. Since the documentation expectation for pressure injury care plans to just have one that's reflective of need, nurses have to review it every day, but not necessarily revise it every shift. The fact that I see here that our numbers are very high is great, but nurses are frequently reviewing their care plan or redoing the care plan every single shift. So that may be that they don't quite understand the practice change, or there's differences in what their judgment is about that patient, with something that continue to be revised going forward as well, so that these care plans are reflective of patients' needs. Plus, some nurses were documenting it in such a way as that they were doing it as that was what they intended to do for their shift, not as a comprehensive care plan going forward that could be valid for a longer period of time. And lastly, nurses have to sign off that they were able to complete their care plan and had an opportunity to make any notes if there was any exceptions to it. So for example, if a patient was off unit for a prolonged period of time, or patients were refusing heel boots or any interventions, for example, nurses can make a note there. It began while I started above our target. We were able to raise it and have it more consistently above our target, where I was signed off more consistently. And to what made me happier as I was doing my chart audits is that I saw that these nurses were actually beginning to make more and more comments as the fellowship or the project continued to go on, which shows me that they were thinking about what they were doing. In terms of how it went, we were able to get enough staff to attend our trainings, do our in-services. Our tests showed that there was an improvement in knowledge, but we're still trying to search and discover whether or not the care plans are being done in a way that's really reflective of our patients' needs. And that requires a lot of just-in-time training, especially as our patients' acuity frequently shift. So lessons learned, changing attitudes of I just want to do my job and go home involves really capitalizing on teachable moments and really having nurses recognize the full extent of all the things that they do as part of their normal practice that really help prevent pressure injuries, and making sure they value and protect and document and really capture all these wonderful things that we do normally. Another thing from our project, looking at improving communication between our PCAs or PSWs or support workers that are on our unit, and allied health and communication between them and the nurses. A lot of times these individuals or these other professionals that we work with are involved in providing treatment, bathing, mobilizing ADLs, and it's really important to make sure we have good communication. So if they recognize early the risk of skin breakdown, we can capitalize on that. Follow through is difficult to predict and not always related to readiness. Often I would have really great conversations with staff. They seemed engaged. They would ask questions, went above and beyond what we were discussing, and it didn't always translate into to what I've seen in chart audits. For the most part, there were very few staff who omitted to document in all of their patients. Usually it was only 1 or 2 when I was doing a chart audit, which was encouraging. And the last thing for my project, identifying more solutions than barriers takes time and patience. And a large part of this I found was really helpful by making sure that our strategies that targeted attitude, agency, and perceived norms about pressure injuries was very helpful. But it really required emphasis and support from leadership about having personal accountability for your practice as well, and I can't stress that enough. So going forward, the clinical instructor who does her ACU courses agreed to incorporate an enhanced skin health and wound care component as part of her learning lab. So as our staff mature, progress, and get the opportunity to do their ACU training, this content will be reinforced. All of the product references, posters, are aligned with the proposed revisions for our skin health policy, changes that are upcoming, and I know that HAC group and skin health committee will be using the stuff that I have done in some way, shape, or form. All of this has been consolidated into a toolkit that's available for distribution to other units. Our sister unit, the other transplant unit on 7AB, will be doing their HAC bundle and their audits of pressure injury prevention. They'll be using the tools that I've been creating. Because we found that poor documentation rates was not unique to skin health or the skin health documentation, it was decided by management that our in charge is now going to have the responsibility of double checking that our staff are completing the necessary documentation every shift. And a final thing going forward is that we are piloting intentional rounding where nurses will round on each patient every hour. It's very clear that every hour patients are being seen by their nurses. And this offers an opportunity for better queuing to reposition patients and addressing continence and moisture issues with accompanying documentation. I feel that along with, you know, all the strategies that I took place on, there was again, a continued sense of accountability that was reinforced by management that really helped improve our documentation practices. The final document chart audit that I did, we actually had numbers that were much closer to 100% across the board, which was very encouraging, especially since on that particular day, we had 100% of our staff be our staff. We didn't have any of our agency or NRT staff present, which kind of confounded some of our numbers at times, since they weren't subject to the full range of interventions that we've been doing as part of the project. But I'm looking forward to doing a random chart audit next week when they think that no one's looking, and just seeing just how well we're doing going forward with improving our pressure injury prevention documentation. Thanks. Oh, sorry. Any questions? Yes. Sure. Mm-hmm. Yeah, I really did want to make sure that the nurses felt very respected by, you know, when I was doing this quality improvement project, and making sure that they felt that it wasn't again, another top-down strategy or perceived as a top-down strategy where we're saying this is best, now go do it. I think they really liked being heard and being seen as being an expert and having their opinions noted. Our unit, for the most part, has nurses that are less than 5 years experience. So in the greater scheme of things, they're fairly junior. So having a moment to talk to them and make them feel that their clinical insights and intuition are important and valid, and they have something to contribute, I think they greatly received well. And then the way that we did the in-service, where people put a variety of strategy, was a way for that nurses to be exposed to different options and ideas in a way that was not confrontational at all, and not saying that this was best, but this is how other people do it. Do you think you could try to do this? And it was, people were, I think, really surprised by the level of creativity that they had when they had to brainstorm beyond it. So it went quite well. It was nice. It was sneaky. It was a nice sneaky way for them to just see how good they actually are and how well they actually are doing, and that sense of importance about making sure that you are capturing that in your documentation. I think nurses are really good at doing very accurate documentation when there's a sense of urgency, or nurses have perceived that there's an increased risk associated with an event going on. And I really wanted to have that same sense of urgency and importance permeate through all the documentation that they were doing. So this was a helpful tool for that, for sure. Thank you, though. Yes. Oh yeah, we definitely do incident reports for stage 1 onwards. And we look into see how because for them it's more of a trigger, because if a patient acquires a stage 1, stage 2 injury, regardless, if the incident report is sent, it goes to the manager directly, and it also goes to the skin health committee as well. So it's a very important trigger for leadership to step in and say, okay, hold on, are we doing the best practice? Did this pressure injury develop on our unit? Or did it develop somewhere else as well, to try and figure out the etiology? Our patients come from their transplant surgery, and they may have had a prolonged time in ICU, for example. They may have, they have a new organ. people aren't like cars can't just switch out parts. They still have a lot of times as they recover with a lot of the intrinsic risk factors associated with their end-stage organ disease that puts them at risk. So the incident reports are really important because it helps us actually stop and look critically before these pressure injuries develop and get worse. Yeah. That's something that I don't quite know the answer to. That's really what the Skin Health Committee does. So they look at it and they decide whether or not they need the extent to which they have to act on it. So if it's something like a stage 3 or above and it's considered a serious safety incident, they do a big debrief about it because that hopefully should not have been a new event. There should have been, we have a stage 1 ulcer and then unfortunately there should have been progression, not a surprise. The particular patient that we had was actually transferred from another facility. So we wanted to also figure out whether or not did this happen somewhere else or did it happen with us? Do we have time for one more? Yeah, we can chat later. Yeah, thanks guys.
Really try to keep on time with these things. So our last speaker is Chang Wen from Toronto Rehab at the University of Health and Work.
Hello everyone, my name is Chen. I'm a RPN of the Transitional Care Unit at Toronto Rehab Medical Center. I have worked on a project on to improve patient and staff experience during care transition where I practice. First, I wanted to acknowledge those who provide supports during this project. I wanted to thank my manager, Marianne, who puts a lot of her time and energy from the beginning to the end. Also, I wanted to thank my mentors, Clara, Maria, Lisa, and Sam, gave me their past experience, expertise, and insight during the mentorship meetings. At last, I want to thank Deborah, Carrie Ann, and all other CAP project manager as well as CAP fellowship fundings for the past 6 months. I will treasure this fellowship experience and using things that I learned to help patients in the future of my nursing career. We were able to create our education materials with additional supports from our UHM patient partner and education professionals, also with our social worker. They responded quickly as the deadline is fast approaching. We will now quickly refresh the identified gaps in practice from midterm, review our implementation process, discuss the results, share what we learned, and looking forward for the future practice and sustainability. Let's look at the backgrounds, its impact, and care transition practice gaps. Care transition described by Health Quality Ontario as the transfer of a patient between care environments and its care providers. It is often discontinuous and poorly coordinated, resulting in poor patient care experience and compromising patient safety. This impact for patients as well as for our frontline staff. Clinicians felt they were failing to deliver what are upheld the most in their value as provider of care. If you remember our patient in 449, the lack of understanding poor communication during care transition had led the patient to sign his long-term care paperwork with his opposite goal of care. He always wanted to go home after rehab treatment. By the time he finds out he's staying on the wrong unit to fulfill his goal, he becomes worried about his future. The physical limitation had greatly impacted his independency, dignity, as well as his mental well-being. Breakdown in communication at critical transition points and confusing discharge plans has contributed to his negative transition experience. We had informal dialogue with 30 patients who are at different stage of care transition across 16 patient units at UHN. We analyzed feedbacks and decided to focus our project on the 3 transition practice gaps during this period. The focus is around discharge, communication, and long-term care readiness. Each area encompasses a wide range of altitude with their uniqueness, yet overlaps on each other. Let's go over what we created, which include the meet and greet process, the welcome package we used, the TCU welcome package checklist, and the care transition roadmap. We welcomed 5 patients on the unit from January to March during our implementation period. The meet and greet process provides orientation to patients in their new care environments. This is the first step for the frontline clinician of my unit, building a trusting relationship with patients and their family. We review discharge plans, bridging the gaps in communication by asking questions and provide answers, and ready the patient for their long-term care destination or other alternatives. Concerns are raised by patient, family members, and staff during the process. Then carry over on the care plans for follow-up if the immediate answer is not available at the time. It reduces gaps in communications as it acts as a reference for all of our team members. Expectations are clearly explained early on so that we are transitioned towards the same care direction together with our patient. This is our welcome package that we give to our new patients during the meet and greet process. It includes a checklist and general information about our units and the facility. Staff review each content with patients or family members for better interpretations. The package also includes other UHN patient education materials. We review the package with UHN patient partner and patient education professional to ensure its simplicity is maintained. The package was revised 4 times after analyzing the obtained feedbacks during our 2 PDSA cycles. The welcome package checklist is used to guide our staff during the meet and greet process. We are checking the box after each certain task has been delivered. Staff and patient both sign off with dates so that we are acknowledged what we discussed and also taking the accountability. Here's a picture of the TCU Care Transition Roadmap. It is designed to help patients oversee their care journey. It visually aids our clinicians to review the possibility of the next steps in care for patients who are still anxious and confused about their future. It also reminds their stay on the unit is not permanent. We are connecting with our visual communication specialists to further refine the roadmap, to ensure it's easy to use, understand by patients despite their medical challenges, and also hoping it can be easily adopted by other units. The current design is not perfect. However, with a touch with our digital artists, the map will help patients navigate through our healthcare continuum as we notice the great potential for this to spread across the organization. Now we will take a look at what we accomplished by examining the patient's feedback and hear what the staff said. I dialogued with 4 participants before our meet and greet process. Out of the 5 new admissions, rated a level of understanding based on the 3 care transition gaps were focused. The blue color represents discharge, the red represents communication, and the green represents long-term care readiness. It is interesting to see the amount of improvement from participant number 1, who has a higher health literacy background as well as and well aware of the care transition issues, compared to those who are more vulnerable and had difficulty to comprehend the process due to language barrier or other challenges. We can see the project has more impact for participant number 2 and 4, but it's still difficult to evaluate the full impact, as the results are anecdotal and more qualitative. I think to promote patient experience during care transition cannot be observed in a short period. Rather, the results should be profound and long-lasting. This does, however, give you some insight to acknowledge the gaps in transition as you see the fluctuation of understanding about the topic varies amongst our patients. Let's hear a full quote from staff, patient, and family members of what their thoughts about the project. One of our nurses said, "It will change the ways to approach our new patient. We will get to know each other better." A healthcare assistant indicated, "Before it's like nobody knows what will happen. Now at least we have something to answer back to them, and they can ask for more questions." A long-stay inpatient told me, "I wish something like this exists when I first got here, because it gave me an idea where I can go after." A patient family said, "It gives you an expectation. I can tell you as a nurse and a family member. This makes the life of a patient easier as it focuses on what's to be done. I know what I want from my mom, but not everyone is a nurse." Some did mention about the negative aspect, such as adding on workloads during busy admission time. But just like any other new process, with proper training, the benefit will outweigh the cost. Staff will see the value over time. In conclusion, care transitions are very complex. The result of an improved care experience cannot be pinpoint measured or compared against like a concrete procedure. It's not like we put a stick on the ground that you see the shadow right away. It requires time, follow-up after discharge patients, incident reports, and survey to be able to illustrate the full success of our project. Let us imagine for that patient from 449, how his transition experience could have if he was properly informed about the care journey live before him. Would it make him more adaptable to his new environment and allowing the staff to transition him towards his goal instead of against it? Tiniest thing matters. We also learn that the smallest thing in patient's life, such as look out the window every morning, pictures on the wall, getting up on the wheelchair, are some example of what patients concern the most in their daily care. It's somewhat contradictory of what our clinicians thought about, as often we're over-focused on the medical aspect of care and ignore the psychosocial, spiritual, and basic human aspect in their care journey. Patient-centered care. Transitioning care needs to be patient-centered before we can improve health outcome. Care transition need to be bi-directional, but currently our focus is only one way. At each transition point, we need to look back to the previous care experience and appreciate the current concern and management. Staff need to understand what the cause and the concerns, consider the physical and mental well-being of a patient. Lessons learned. We now know some patients have low cognitive capacity to appreciate the efforts. Some are less fortunate in terms of supports or has no supports. We also realize sometimes patients' expectations exceed with what our resource could deliver. It is natural to wish for more, especially in terms of healthcare, which make care transition challenging considering our limited resources. We will continue to work closely with all disciplines, putting patients' needs before all else. Utilize our resource efficiently during care transition. I have to admit, the newly developed process had many flaws, but I will continue to refine it as my MPPL project for this year. Additional work are required to adjust our approach towards mentally challenged patients. Incorporate the project as a part of our mission process for sustainability so it does not stop after the fellowship. In addition, the impact of this project will affect the way of addressing transition on local unit level. It has potential to spread to other units with higher turnover rates within the facility. It could serve patients on waiting lists from referring units across UHN as it helps reduce patient anxiety of the unknown future in their care journey. Before the fellowship, I was a frontline nurse who wanted nothing but the best care for my patient. Of course, I never had experience for any major project, so I was nervous when I heard about the CAP. I do not see myself creating something that could help my patients aside from giving medication or changing their dressing. I was always listening to my patient's concern, but never realized what deep within the issue. Now I'm more confident not only for project management. Moreover, I listen to patients' concern from a different angle. I can acknowledge the underlying issue after fixing the superficial ones. There are still many things for me to learn on how to provide holistic care for patients, which made me very excited and looking forward to work every day. Anybody have questions? Thank you.
Thank you, Chang, and amazing for strong presentations today. Thank you to all of you. So now we have Lisa Di Prospero, Director of Practice-Based Research and Innovation at Sunnybrook, to give the closing remarks. Thanks.
Thanks, Sarah. First of all, congratulations. I know we have a small group of fellows today, but you did awesome. So thank you for sharing your presentations with us and all the great work. I would like to start by thanking once again our faculty, Sarah, Deborah, Carrie, Nicole, Guna, and Bridget, our donors. As you know, the fellowship program is also supported by generous gifts to support all these opportunities that we offer our clinicians. Our patient partners who are involved in selection, in priority setting of this work, our directors and managers, our senior leaders who continue to see the value and impact of the program, and our clinical teams. Always want to thank them because they really drive the integration of this work into practice. And we saw that by our fellows when they were talking about their idea moving forward and really being integrated into change. Last but not least, I thank all of you, our fellows. This is the final day of our presentations. We're actually on day 4. And I'm struck by the immensity of your curiosity, commitment, passion, and courage. The courage to challenge yourself and all of us to make a change within the system. Thank you for your advocacy to influence the healthcare system that affects us all as clinicians, as family members, and as patients, because this is our system. We're all accountable and it is all important to us. This transformative journey you're all on is just at the start, and I'm humbled as I see each of you aspire and transform into great leaders, and we see that with our alumni moving into various positions, moving through organizations, and really impacting way beyond the fellowship. We're so proud of all of them. And I'm confident that this journey will take each of you to very big things, and I always put that in quotations because I'm always amazed at where our fellows end up. And I leave you with a few words of wisdom that I have borrowed. The only impossible journey is the one you never begin. So thank you, all of you, again for coming. Congratulations to our fellows. And please, I invite you to network and join us to look at the posters that our fellows have put together. So thanks.